Morning to all of you. At the outset, I'd like to thank All India Ophthalmological Society Scientific Committee and our Chief Instructor, Dr. Twinkle, for giving me this opportunity to share my views on the topic of accurate keratometry and biometry, and thereby aiming for better IOL power calculation. We all know that IOL power calculation comprises mainly of three factors: calculating or measuring the power of the cornea, the axial length of the eye, and using this data to get an ideal intraocular lens power. Precision in keratometry has taken a whole new change. We have now multiple instruments doing multiple things. So, which is the best technique? Let us go into details of most of them and try to find out why are we all actually worried about keratometry. We all know that a diopter of error in measuring the power of the cornea will translate to a diopter of error in measuring refraction. It is basically measuring mainly the anterior curvature of the central cornea, central 3 to 4 millimeter. There are various methods involved: manual keratometer, auto keratometer, a topography or a topographer, and the optical measurement methods like the IOL Master and the Lenstar 900, plus there are multiple other things also. Keratometry is mainly expressed in either diopters or millimeter in radius of curvature. For manual keratometry, you have two working concepts. One is the Bausch and Lomb keratometer, which works on the concept of fixed object size with variable image size, and a Jewel Shades, which works on the principle of fixed image size and variable object size. And there are prisms involved to overcome the error of eye movements. Key things which we need to take care while measuring is the measurement should be in a low ambient light. We need to ensure a good quality tear film. The eyepiece should be adjusted so that the central crosshair is very clear. Make sure that the patient's other eye is closed and that the corneal Mayas are exactly centered on the cornea. Take multiple readings. And in a scarred cornea, fellow eye can be taken. There are certain difficulties. One is a poor fixating patient, a poor tear film, a nystagmus, and a post-refractive surgery patients. Keratometry should be here measured by using topographer or tomographers. This is one thing which we all normally never do, is calibrating our keratometers. So there are various methods to do it. You have ideal spheres or you have lenses which can be used to calibrate our keratometers. These are mainly for manual keratometry. Sources of error: obviously an unfocused eyepiece, failure to calibrate the unit, poor patient fixation, dry eye, drooping of eyelid, and irregular corneas. There should be validation criteria for all measurements, and same thing applies for keratometry also. If the corneal power is less than 40 diopters or more than 47 diopters, an average difference of corneal power between two eyes of more than a diopter, if the astigmatism is more than 4 diopters, or if the astigmatism is correlating poorly with the refraction, you have a previous refractive surgery eye, or if you are not sure of the measurements, it doesn't make any point in being unsure and then entering those values into your IOL power calculation. So you can use multiple machines also to take the same readings. Autokeratometer is a bit faster. The advantage here is because it uses light emitting diodes to project the Mayas, and the detection is done by a solid state detector. So the error of spontaneous eye movements is much more less with autokeratometers, and probably that's why slightly reliable if used properly. In special situations, you have handheld keratometers, especially in infants or people with supine position. It should be taken care that the visual axis remains parallel to the plane while you are taking the measurement. There are newer methods, topographers, which allow us to actually measure the curvature of the anterior and posterior curvature of the cornea. It also helps to do a point-to-point pachymetry. You have tomographers, which create a three-dimensional models of the cornea and then extrapolate the power of the cornea depending upon the cross-sectional images. Various technologies have been evolved. There's a three-dimensional topography, there is a slit scanning method, which is normally used in OpScan. There is a Scheimpflug imaging method used in Pentacam. You have high-resolution anterior segment OCT in Visante. So there are various methods. All of them have their pros and cons. These new technologies enable us to measure the cornea, yielding information about the curvature, power, and shape. Certain methods also help us to measure the anatomy as well, like the flap placement post LASIK or a depth of the scar. We can also use them to finalize the depth of the intracorneal ring segments. Broadly speaking, if you divide these two parts of the machine, they are into either reflection based or Scheimpflug based, both having their advantages and disadvantages. Just to make a small comparison, you have the manual keratometry, which measures the central 3.4 millimeter. You have a automated, which measures about 3 millimeter. You have Pentacam, again measuring about 3 millimeter of the central cornea. You have an Auto-K, which measures about 1.9. An IOL Master measures about 2.3 of the center. And a Lenstar, which is slightly better because it measures multiple points at two different radiuses. So this is all about keratometry. Going to biometry, we all know that it's a process of measuring the axial length of the eye. Again, why this is more important. 1.75 diopter error per millimeter of error in long eyes, and up to 3.75 diopter of error per millimeter of error in measuring short eyes. So this is very important. Even with the best of the surgeries, your final result will go haywire if you are not sure or if you are not correct in measuring the axial length. It basically uses an ultrasonic energy and depends upon two different principles of piezoelectric phenomenon and acoustic impedance. You are projecting an ultrasonic wave which is coming back, and you are measuring the time. The principle here involved is distance is equal to velocity upon time. The velocity of ultrasonic waves in different medias have been available, and you can vary them in certain machines also. Even in pseudophakic eyes, you have correction factors which can be added up to give you an ideal axial length. There are two things which are important. One is resolution and second is gain. Try to measure with the minimum gain possible. In slightly denser cataract, you might need to increase the gain of your machine. This is a small comparison of phakic and pseudophakic eyes. There are various methods of biometry. Contact biometry, though a bit difficult doing an accurate contact biometry, because the gain should be at the lowest level. You should not push too much, otherwise that will create a depression in the cornea. The average, about 5 to 10 consistent readings should be taken. However, surgeons who are really interested in highly accurate outcomes should now abandon contact biometry and switch over to something which is slightly better, which is an immersion biometry. It is accurate because no corneal compression is involved, and measurements are really close to the true axial length. And contrary to popular belief, it is quite simple, and it is faster as compared to a contact biometry because the readings takes bits lesser time when you are doing it correctly. There's one more method which is more sophisticated, which is combining an AB scan. So how do you interpret? You take a single best scan, magnify it, edit the each spike and check the anomalies and print it out and compare to the other eye. This is for an contact biometry. You have the spikes for the anterior and posterior capsule as well as the cornea, retina, sclera and orbital fat. In case of immersion, the first spike will be moving slightly ahead, so there will be a first spike of the contact of your immersion scan with the fluid, and rest of the spikes remain the same. These are contact and non-contact scans for a proper beam alignment. If it is slightly off axis, your lens spike will be, the posterior lens spike will be slightly uneven as compared to the anterior lens spike. If the beam is not on the macula and the optic nerve, you will see that the scleral spike is missing. If the beam is not perpendicular, the retina spike itself won't be perpendicular. So these are certain things which you need to be taking care while you are selecting your correct measurements. Causes of error we all know. There are again validation criteria for biometry also. If there is more than 0.3 millimeter difference between two eyes, axial length which is too short or too long, and axial length not correlating with your refraction or your glass power, difficulty in positioning the IOL, and fixation problems. 50% of your all postoperative refractive surprises are from your A-scan errors, and error of 2 diopter or more is mostly related to your A-scan. So it is very important to be sure of what you are doing. However, there is a limitation. The broadness of the 10 millihertz ultrasonic beam creates errors, and to take care of this, now you have newer technologies such as the non-contact one, like the IOL master, which uses the partial coherence interferometry and the Michelson principle. It not only measures the axial length, it also measures the AC depth, lens thickness, keratometry, and white to white. You have multiple formulas built in. These are the spikes. One thing which we need to be aware of is the sound noise ratio. If it is more than 2, it is a valid. If it is between 1.6 and 2, it's a borderline case. You need one more measurement. If it is less than 1.6, it is probably not usable. Advantages are immense. It is easy. It is a non-contact, no water bath is required, can measure through glass, accurate measurement in silicon field eye, and you have multiple formulas available. One more addition to this is LensStar. This is slightly more better as far as measuring the keratometry is concerned, because 2 zones are measured and multiple points are measured. However, the most important process is you. If the measurement don't make sense, please investigate. Retake the measurements, have a second person to verify it if you find there is something wrong with what you are taking. And even with the advent of IOL master, you need your immersion skills ready, because there are certain situations where IOL master won't be working that well. In Brunnerson cataracts with a central posterior capsular plaque, in vitreous hemorrhage, or a scarred cornea. So this is where your immersion technique is going to save you. There are other things also which are now on the horizon. Various methods like the machines like the Aladdin from Topcon, or the AL scan or OPD scan from Nidec. You have Galilei from Zimmer, and all these are doing multiple measurements and also helping the surgeon to measure the IOL. These are the strength and weaknesses of each of these machines. And last but not the least, just to aid, you have Intraop guidance now. You have Callisto, you have TrueGuide, and you have Varion. So all these are coming up, and they are helping surgeons to make sure that the IOL power calculation is to the point. You have exciting times ahead, and we are sure that we'll be reaching the goal of target emetropia with using this newer technologies. Thank you.